Welcome everyone to Transfusion Vitals. I'm so glad you are here. Today we are diving deep into one of the most critical topic in blood banking and clinical medicine, transfusion reactions. Whether you are a medical student, a resident, a blood bank technologist or a nurse at bedside, understanding transfusion reactions can literally save a life. In this session, we will cover everything from definition and classification to the mechanism, clinical features, investigation, and management of each major reaction type. So, don't forget to like, subscribe, and hit the bell icon so you never miss an update from Transfusion Vitals. Let's start with the basic. What exactly is transfusion reaction? The International Society of Blood Transfusion or ISBT defines it broadly as any adverse event occurring during or after transfusion suspected to be related to it. The WHO echoes this. It is an unintended harmful response in the recipient. Two bodies, one message. When in doubt, stop the transfusion and investigate. Now let's put this in perspective. How common these reactions? ABO incompatible transfusion occur in about 1 in 40,000 transfusion, mostly due to human errors, not the lab mistake. Acute hemolytic reactions, the most severe, occur in 1 in 76,000. Interestingly, 47% of ABO mistransfusion cause no adverse effect, probably because very small volume were given. But we should never count on that. The risk of death from ABO incompatibility is estimated in 1 in 1.8 million transfusion, and in the US it causes about 10 to 30 deaths per year. These numbers remind us that every bedside check matters. Reactions are broadly classified by timing. Acute reactions occur during the transfusion or within the first 24 hours. These are the ones you need to recognize immediately at the bedside. AHTR, FNHTR, allergic reactions, TRALI, TACO, and septic reaction. Delayed reaction, as the name suggests, manifests days to week later. The most important is DHTR, delayed hemolytic reaction, which often present as an unexpected drop in hemoglobin after what appear to be a successful transfusion. TAGVHD, though rare, is often fatal. The golden rule: any patient who deteriorates after a transfusion, even days later, must be worked up for a delayed reaction. Classification by the mechanism. Immune-mediated reactions are most clinically significant. They involve patient immune system attacking transfused components. AHTR, FNHTR, allergic reaction, TRALI, and TAGVHD all fall here. Non-immune reactions include TACO, transfusion-associated circulatory overload, which is purely mechanical. The heart cannot handle the fluid volume. Hypothermia and electrolyte issues are also occur with rapid and massive transfusion. Physical or mechanical cause include bacterial contamination, a platelet product left out too long, or hemolysis caused by improper storage. Understanding these mechanisms help you choose the right treatment. Let's now go into the most feared transfusion reaction, the acute hemolytic transfusion reaction or AHTR. This is a reaction that textbook warn you about, that examiner ask about, and that clinician dread at the bedside. Why? Because it can be fatal and it can happen within minutes of starting a transfusion. In the next few slides, we will walk through everything: the cause, mechanism, the symptoms, the investigation, and the treatment. So, here where life saving decisions happen. Let's trace the pathophysiology step by step. Step 1. The patient already has a natural occurring IgM antibodies against A or B antigen. For example, a group O patient receives group A blood. Step 2. These IgM antibodies immediately activate the classical complement pathway. C3A and C5A are released, powerful anaphylactoxins that cause vasodilatations and inflammation. The membrane MAC begins to form. The MAC5B C5b to 9 punches hole in the donor RBC membrane, intravascular hemolysis, free hemoglobin floods the circulation. Step 4, free hemoglobin binds to nitric oxide, which causes vasoconstriction and hypotension. RBC stroma activates the platelets coagulation and it will cause DIC. Step 5. This free hemoglobin and RBC stoma damage the renal tubules, acute tubular necrosis, renal failure. So this cascade happened very fast within minutes. That's why early recognition is everything. Now, what does the patient actually look and feel like? The classical triad to remember is fever plus back or flank pain plus dark urine, that is hemoglobinuria. If a patient develops these during or shortly after the transfusion, stop the transfusion immediately. Fever is almost always the first sign. Then hypotension and tachycardia as shock develops. The oozing from the IV site is a sinister sign of DIC. One clinical pearl is in the as soon as you are suspecting the AHTR, here is your investigation checklist. First, stop the transfusion. Don't remove the IV line. You will need it. Second, send the unit back to the blood bank intact with all labels and the transfusion set. Third step is very crucial, that is the clerical check. Most AHTR are caused by giving the right blood to the wrong patient or the wrong blood to the right patient. A bedside identity check can catch this. In lab, spin down the post-reaction sample. Pink or red plasma will be known as the hemolysis occur in the patient. Run the DAT, repeat ABO typing on the unit and the patient, run antibody screen. For hemolysis marker, free hemoglobin, hemoglobinuria, haptoglobin very sensitive, it drops dramatically in hemolysis. The LDH goes up. We have to check for the DIC. For that, you have to look for PT, APTT, fibrinogen, and platelets. Always send a urine sample for hemoglobinuria. Treatment of AHTR is primarily supportive. Stop the transfusion, maintain IV access. Your main goal are to protect the kidneys, keep the urine output above 1 ml per kg per hour, use IV fluid aggressively, add furosemide if needed, treating shock by starting the fluids and if needed low dose of dopamine. For managing DIC, you can use FFP, fresh frozen plasma, cryoprecipitate, or platelets depending on the coagulation picture. There is no specific antidote. The damage from the antibody complement cascade is already underway. So your job is to minimize the organ damage. For prevention, and this is the key, most AHTR are preventable. This happened because of the human error, wrong patient, wrong unit, barcoding system, electronic identification, and a strict 2% bedside check have dramatically reduced these incidents in countries that have implemented them. This comparison table is one of the most commonly tested topics. So let's nail it. AHTR is the acute reaction happen within 24 hours, usually because of the preformed IgM antibodies. So think about ABO incompatibility. The hemolysis is intravascular, the complement punches holes directly in the RBC. It is severe and potentially fatal. The next is DHTR, that is a delayed reaction. So happen 3 to 14 days later, sometimes up to 28 days. It is caused by the anamnestic IgG antibodies. The patient was previously sensitized. The antibody level drop below detection and re-exposure to the antigen triggers a rapid secondary immune response. The hemolysis in DHTR is primarily extravascular. Splenic macrophages engulf the antibody-coated RBC, so you won't see hemoglobinuria. You will see an unexpected drop in the hemoglobin, new positive DAT, and jaundice. So always remember, DHTR is often mild but missed. The patient may be discharged and come back with the anemia days later. So regardless of which reaction type you suspect, here is a universal algorithm to follow the moment you suspect any transfusion reaction. Step 1. Stop the transfusion. This is non-negotiable. Every second of continued infusion worsens the outcome. Step 2. Keep the IV line open with the normal saline. You need it for the medication, fluid, and to maintain the vascular access. Step 3. Assess the patient. ABC, airway, breathing, and circulation. Are they breathing? Is the blood pressure holding? Step 4. Call the blood bank immediately. Return everything, the bag, labels, the administration set, because they need to investigate on their end. Step 5. Draw the post-reaction sample and send the urine for the hemoglobin. Step 6. Clerical check at the bedside. Is this right patient? Is this the unit right? Many HTRs can be caught here. Step 7. Initiate reaction-specific management based on the clinical diagnosis. Step 8. Document everything. Report your to the hemovigilance system, and this data saves the future patients. And that's, my friend, bring us to the end of today's deep dive on the transfusion reaction. If you found this session valuable, please give a thumbs up. It really helps the channel grow and reach more student and healthcare professions like you. Don't forget to subscribe to Transfusion Vitals for more high-yielding session on the blood banking, cross-matching, component therapy, and the blood transfusion practices. Drop your questions or topic you would like me to cover in the next comments below. I will read each one of them. Until next time, stay curious, stay careful, keep saving lives. This is Transfusion Vitals signing off.